Today we're going to be talking about Mary, a 72-year-old patient who had a total hip arthroplasty around 3 days ago. She has since been admitted to this transitional care unit, and now we are going to begin with her occupational profile. She's chronologically and developmentally 72 years of age. She has had progressive pain symptoms in the last 2 years and could not bear it anymore in her left hip, so she had this surgery as an elective choice. Her precautions are that she has consistent and often burning pain, as well as she has a fall risk. Her relevant physical medical history is that she has osteoarthritis in her upper extremities, hypertension, and multiple UTIs in her history. She is seeking services to be able to take care of herself and her belongings at home safely, as well as be independent from adaptive equipment. The client lives alone 2 blocks away from her sister. Her suburban home has 5 stairs to enter and 12 stairs to go up to the second floor, which contains the bedroom and the bathroom. She does not own any medical equipment aside from the cane that she has borrowed from her sister. She's currently residing within a transitional care unit, but before that, her day consisted of a morning self-care routine, volunteering at the library, and playing cribbage once a week. She was completely independent in ADLs, IADLs, and community mobility prior to the progressive hip pain, but acknowledges that her morning routine is now difficult and slow, she needs a cane to ambulate, and that she avoids walking and climbing the stairs as much as she can. She perceives that she cannot live alone and function independently in her home post-op, and agrees to stay 1 to 2 weeks in the transition unit. Her therapy goals are to go home quickly and independently care for herself and her home without adaptive equipment. This and her storytelling to the children at the library are what motivates her to improve for discharge. So, going into her specific OT evaluation, with ADLs, we need to assess at the next visit toileting, feeding and eating, as well as grooming and personal hygiene, and personal assistive device management. At least with feeding and eating and grooming and personal hygiene, we can assume that there is a strong level of independence since she was able to do fine and gross motor coordination with no problem. Her upper body dressing and bathing was independent as well in regards to the original OT eval. Her lower body dressing and bathing was not applicable to this because of her hip precautions and her fear of re-injury and use of adaptive equipment. Moving on down to functional mobility, her bed mobility was needed with moderate assist. An OT or nursing staff member has had to help her roll in the bed to prevent pressure ulcers. Her bed-to-chair mobility and toilet transfers needed max assist. She provided little help for herself, and the OT had to do most of it while holding on to Mary as she was in a squat pivot position. Her tub and toilet transfers need to be assessed at the next visit, but her ambulation and assistive devices for mobility management is with modified independence since she can use a walker for transfers. Comments on this is that she is refusing adaptive equipment at this time to aid in the recovery process and is behind on treatment goals. Client is very fearful of injury and pain, and she is right-hand dominant, so should not have much difficulty with feeding and grooming with that full function of the right hand. Beyond basic ADLs, her sensory integration is within normal limits. Play skills and education concerns are not age appropriate at this time. And then looking forward to observations and physical evaluations. With the shoulder, we see bilateral impairments from the OA, causing only 2/3 of the arc of motion to be able to be reached with AROM. No PROM measurements were taken and would need to be assessed at the next visit. Her forearm, elbow, wrist, and digits were within functional limits for her right side, and mostly for her left until she reached the digits. At that point, she did have an impairment due to the OA and the inability to make a full fist. With the manual muscle testing, we can see that the shoulders had a fair minus score, and that means that they are impaired and the joint can only move around 50% of the full arc against gravity. Moving down past the shoulders bilaterally, the elbow, forearm, wrist, and hand got a fair plus rating, except for the left with the fair minus. But the fair plus means that the muscles can hold slight resistance against pressure before breaking. Lastly, all sensation was within functional limits and no edema was visible in the upper extremities. Her grip strength was impaired as well as her pinch strength in the left hand. She could not make a full fist or full flexion without pain, but the right side was within functional limits. Muscle tone for upper extremity, lower extremity, and trunk and posture, as well as postural alignment, need to be assessed at the next visit. In regards to her coordination, both her gross motor and fine motor on bilateral sides were within functional limits. Her motor planning could be assessed at the next visit, even though cognition is within normal limits. Her pain is an impairment, mostly, because it's progressive and debilitating to the patient, and the fear of re-injury can cause disuse. Her coordination, as a comment, was only found for upper extremity, and due to hip precautions was not for lower. But general lower extremity appearance was that she was able to move volitionally with assist, has edema in her left leg, as well as an incision site there. In regards to her sitting balance, for static sitting balance, she was safe in the chair. For dynamic sitting balance, she needed mod assist, and the functional endurance was that she could tolerate it about 2 minutes. For her standing static balance, she needed max assist, as well as her dynamic standing balance was max assist, and could also tolerate it with an impairment for around 2 minutes. Comments here again is that she is afraid of re-injury and weight bearing and provides little help during transfers. Her vision and perception is that she needs glasses, but her perception is within functional limits. Her hearing, communication, and cognition are all within functional limits, and she is A&O times 4, following all step commands around 80% of the time, unless there is frustration involved and unwillingness to use adaptive devices. Her specific mental functions include her not giving her undivided attention to her injury and proper care of it, as well as hesitation to initiate transfers and weight bearing, and emotional fearfulness of re-injury. Her global mental functions are that she was A&O times 4 but was at risk for pressure sores due to her sleeping position. Her method of communication is that she was completely verbal and fluent as she was a teacher and reads to children in her free time. So moving on to her goals and treatment plan, anticipating some of the obstacles for Mary in reaching her goals is that she may need the use of adaptive equipment and proper education on how to use it, but she is refusing it at this time. She wants to go home without any of the gadgets. Her current level of function is not within functional limits for a discharge for 1 to 2 weeks. She will not be safe nor following her hip precautions properly. Some of the difficulties as a therapist trying to deal with a patient that can be frustrating at times is trying to work and balance between her frustration and yours, as well as her unwillingness to accept proper help and care for her post-op treatment. It can be hard to know a patient can want to go home with not being safe. So posterolateral hip precautions are that to tell Mary is that she can weight bear on her leg as tolerated, avoid stepping backward and bending down below a 90-degree angle, avoiding crossing her knees, as well as keeping her toes forward. So some devices for her to help adhere to that while she's toileting or sleeping would be a raised toilet seat or portable toilet, as well as an avoidance of weight bearing on the left extremity during sleep. This can help with avoidance of crossing the knees as well as squatting too low. Having Mary perform her ADLs given her limitations would be as weight bearing as tolerated, as well as continuing to encourage and educate on the use of adaptive devices to compensate for temporary weakness. The portion of her ADL routine that I will anticipate to be most difficult for her is going to be lower extremity dressing and bathing, as well as transfers, due to the hip precautions, pain, and fear of re-injury. Adapting to that would be trying to get her to be educated on the benefits of a shoehorn, a sock aid, and a dressing stick, as well as even a long-handled sponge for bathing. She is currently using a walker for transfer, so I would suggest she continues to until she's properly healed and confident in her weight-bearing abilities. Her ability to prepare a meal, as long as the proper setup is there and she does not have to squat down or reach up too high to retrieve pans or plates, I think Mary will only have slight difficulty preparing a meal with her OA and her upper extremity joints. Some of her social needs that could be fulfilled at the unit would be that she finds a strong connection with storytelling and reading to children at the library and likes to play cribbage. Modifying these activities can be very simple. Cribbage can be set up during free time at the transitional unit, and Mary could play with other patients if they're willing. She could also read to them in the same case. If Mary refuses to use the adaptive equipment, some alternatives to offer is just light weight-bearing activities every hour or so that she doesn't acquire any disuse syndrome or pressure ulcers. This can help promote strength maintenance during her healing phase. So questions to ask her about environmental adaptations for her home would be, Mary, how confident are you to go up and down the stairs independently without worrying about re-injuring yourself? Would it be easier than to install a chair lift for your safety? Are you confident in climbing the stairs to enter your home, or would you feel more comfortable with a portable ramp for the time being? An approach to take to reintroduce that adaptive equipment would be telling her that life is not enjoyable if one has to worry about re-injuring themselves with daily activities, reminding her that it's essential to fully participate in her life, and reintroducing it with proper education first, and then trying to reduce the stigma around such devices. Her safety is a primary goal of ours, and I will remind her that these adaptive equipment devices can help her live more independently than she would at risk without it. In a neuromusculoskeletal sense, I can ensure that she regularly takes her prescribed NSAIDs for the OA, as well as work on dynamic strengthening of her muscles to improve or maintain strength. Her sensation is within normal limits. Mary says she'll participate in only one group on the unit. I would say that home management would be the best group to participate in, because this way therapy staff can ensure safety but also allow her to understand her own limitations that she could experience on her own at home if she continues to refuse adaptive equipment. Physically understanding that versus us telling her can really do some wonders. So, how do I think that she's dealing with her transitional care placement? I don't think she's doing very well with it. She just wants to go home and doesn't want additional help. Her coping mechanisms are kind of unhealthy as she constantly denies it and ignores the situation. She focuses on going home but doesn't want to discuss her surgery or look at her incision. Preventing myself from responding negatively to Mary would look at just reminding myself that she's a person in pain and she is allowed to be afraid. I may get frustrated internally with her lack of cooperation, but I will continue to instill confidence in her that I am not giving up. Some other psychological concerns would be sending her home and her showing early signs of depression and anxiety. She's very down about her current situation and avoids getting better for fear of re-injury. Educational information that's essential for Mary is that safety purposes when dealing with self-care and home management are crucial. She should be educated on adaptive equipment even if she opts out of using it. This protects Mary from re-injury and the OT from liability issues. So if Mary has a nursing assistant doing all of her self-care for her, I could say, Mary, how are you feeling today? How much pain are you feeling today versus yesterday when I saw you? Can you start our session by going through the steps with me on how you plan to dress yourself at home? Doing it and say the nurse is around halfway through. I would just come in and say, Mary, I see you started your morning routine. Let us work together to finish it and assess how you will do these steps when you get home. Overhearing Mary talk about me in a negative way, it's not going to bother me because I can understand where she's coming from. I won't say anything to her, but at the next session I will remind and educate her on the benefits of adaptive equipment. I don't think it would bother me immensely if she does say that, because it is common for people who once were independent to struggle with feeling like they have reverted to dependency. Working with her, and if she does not want to weight bear, I would sit her down at eye level and explain to her that the leg is going to weaken if she does not continue to make it stronger. And if she does have experiences of extreme pain, I would immediately stop treatment and get assistance or a physician referral to put her in a safe position. I would document it with a copy of a physician referral, as well as report her pain sensation in the subjective notes and what we did to help in the objective portion. Beginning discharge planning would be showing progress with her deficits and understanding of adaptations that will help her function independently. as well as knowing that she needs to be independent because she lives alone. Her sister would not play that much of a role in that, and Mary could continue seeing outpatient OT services for around twice a week for however long they see fit to enhance strengthening and IADLs. I would definitely recommend continuing OT services at home to ensure follow-up care and safety for the patient.